All right, so it looks like the number of attendees joining has slowed down. So I'll go ahead and introduce our speaker today. So the Informs Health Application Society is honored to have Dr. Turgay Ayer present his work today. So Dr. Ayer is the Virginia C. and Joseph C. Mello Endowed Chair and the Research Director for Healthcare Analytics and Business Intelligence in the Center for Health and Humanitarian Systems at Georgia Tech. In addition, Dr. Ayer holds a courtesy appointment at Emory Medical School and serves as a senior scientist at the CDC. His work focuses on analytics for healthcare, social good, and socially responsible operations. And his work has been not only published in top-tier business, engineering, medical, and health policy journals, but also widely covered in popular media outlets, including the Wall Street Journal, Fox TV, Washington Post, NPR, and US News, among others. So his work is supported by various federal and other external grants, and he's received many recognitions, including the NSF Career, first place in the MSOM Responsible Research in OM, and first place in the MSOM Best Practice-Based Research Competition, and the Informs Friends Element Laureate Award. And he's active in Informs. He was the previous president of the Health Application Society. And he's currently on several editorial boards, including an associate editor for management science. So I don't want to take up much more of your time. So thanks, Turgay, for doing this, and I'll hand it off to you.
Good afternoon, everyone. Thank you again, and Melike and all organizers for the opportunity. So let me go ahead and share my screen. Let me make this full screen. Okay. I assume you can see my screen, right? All right, so here's the outline that I have for today. I'll do basically three things. First, I'll share my perspectives on practice-focused healthcare operations research. My primary motivation is that I'm assuming there are some young junior researchers in the audience. I would like to at least give them some perspective, share my perspectives, and with the hope that it will be helpful to at least some of the audience. And then in the second part, I will showcase two selected projects, one in scarce resource allocation in public health, focusing on hepatitis C treatment prioritization in correctional facilities, and the second one focusing on blood supply chain management. I will not get into the technical details. I would like to give a perspective. All of these studies are published, and I'm happy to share any studies, any of these studies, if you contact me later. And also, if there are questions, I would prefer that you save them to the end so that, I'll try to finish before the full hour so that, hopefully towards the end, we'll have at least 10-15 minutes of discussion time. So let me start with sharing some of my perspectives, my research, and give you a sense of my research philosophy, research flavor. Before I start any research project, I tend to ask some of these questions that I listed here. The first one is whether the problem is important, significant from a broader perspective. Right? And the thought here is that if the research is successful, does it have the potential to make a difference in a meaningful way? Second, I ask whether it's interesting from a scholarly perspective, right? The problem could be very interesting, but it may not be interesting from a scholarly angle. It may be more like an MBA project. And in that case, it basically is a no for me. The third question that I ask is whether the specific questions are relevant to my own community. They may be interesting problems, but may not be necessarily interesting for the Informs community. And finally, whether I am the right person and my research group, are the right set of people to work on that problem or set of problems. Right? They may be interesting from a broader perspective, scholarly perspective, Informs perspective, but our group may not be the right set of people to work on these problems. And if the problem on hand satisfies these criteria, I typically move on to further dig into the space and better understand the landscape. And for understanding the landscape, I tend to follow some key medical health policy journals such as New England Journal of Medicine, JAMA, Annals of Internal Medicine, and sometimes domain-specific journals, depending on the domain, if it is related to cancer, Journal of Clinical Oncology, if it is related to heart diseases, circulation, if it is related to health economic modeling, value in health, etc. In addition to following these journals, I also find attending medical/health policy conferences very fruitful, where I may have meaningful interactions with domain experts. And once I identify a broadly promising area, early on I tend to engage with practitioners and domain experts. What I typically do is I typically find at least one domain expert. Could be a physician, could be a practitioner, and an end user, right? So if we come up with a practical solution, who would be the ultimate end users of that solution? Whether it's an NGO or a health policy organization, governmental organization. And the idea is before we invest in, I would like to have some further discussions to better understand the problem and also the scope. And in those discussions, I tend to listen to them carefully and understand the domain and their pressing problems in depth. And I tend to push myself for being open to getting out of my comfort zone, even if I have no idea at first about the potential solution approach, right? So I think sometimes early on, I also tend to have that tendency to think about the solution approach very early on. But I basically stopped doing this for a long time. I may be clueless about the solution approach, and if you are too much focused on the solution approach, you may miss a lot of opportunities while discussing these questions with the domain experts. And finally, I tend to cross-check and validate my understanding frequently. Even if it may seem redundant at times, because I've experienced that, there were several misunderstandings based on earlier conversations, and that typically leads to waste of time for everyone. And another important piece of element that I consider is incentive alignment or incentive misalignment. Sometimes, you may identify very interesting problems, you may have the right set of people to collaborate with, etc. But the incentives may not be well aligned, and there are several reasons for incentive misalignment, including possibilities that your potential clinical policy, health policy collaborators, etc., they may have no incentives for publications, right? You may be working with a governmental agency, and they may want to just improve their current processes, but a publication may not be a big incentive for them. And that is a problem, right? Because, in terms of the key deliverables, as a researcher, you may be thinking about publications as a key deliverable for them. An implementable solution may be the key deliverable. From time to time, it may be okay. You may, occasionally you may be able to meet both objectives, even though there is incentive misalignment. But based on my experience, when this incentive alignment is not there, it becomes harder to have a successful collaboration. Second, they may have incentives for publications, but they may have no incentives for operations, research, management, science informed types of publications, and that's more common. Majority of the clinical audience wouldn't have a lot of incentives or enthusiasm to publish in our key journals. And one way that I find it useful to address this problem is I tend to initially publish in clinical health policy journals with the clinical audience first, in the journals that they consider as their key journals. And once we have a good understanding of the landscape, depth of the problem, etc., ORMS, publications typically follow. Even though this may not be the best incentive for them at that point, basically, they have the responsibility to also, be part of these technical publications, and they feel invested in and are typically willing to contribute to that. And a third reason for not having the right incentive is that the type of problem you're proposed to work on may not be on their critical path, right? It may be a side project for them, and in my experience, this is not unusual, right? They may have a side project in mind. They may just propose it to you to explore on the side, and for you it may sound like a great problem, but it may not be on part, on their critical path. It may not be part of their R grants or K grants, etc. And unless you really know what you are doing there, in my experience, this is not the best way to invest your time and focus on, because again, at some point when they get busier, because they are typically busy people, those collaborators, as they get busier, these would be the type of first projects that they drop off. uh, so understanding what is on their critical path, what are their priorities when it comes to research publications, etc., is key. The final constraint could be time constraint. So right here, these people tend to be very busy people, and unless you're working on problems that are really deep to their heart, they may never have the right time to spend on these type of problems. And I try to understand the dynamics, hierarchy, organizational structure, etc. early on to have a good understanding of their incentives, their capabilities, their constraints. And a useful practical strategy that I have developed over time is that I almost always ask them to invest into those projects in one way or another, right? It could be investing in through financial support. It could be through including one of their research team members, uh, or in any other way, right? So that or through some sort of a time commitment, right? Hard time commitment, in kind support. But unless this upfront investment is clear, again, this is an indication that if you are not willing to invest their resources one way or another, this is an indication that this project may lead to a failure down the road. So with that, I'll pause for a second and see if there are any quick questions on those strategies that I discussed. Otherwise, I'll continue with covering the selected projects that I just mentioned.
I don't see any questions in the chat.
Let me
Another
keep going
second,
then.
but if there's no questions in about like 15 to 20 seconds, I'll just let you continue and then we'll take questions at the end.
That's good. So the first project that I'll discuss is on allocating hepatitis C treatment in US prisons. This is joint work with two of my past PhD students, Ken Jong and Anthony Bonifonte. Ken is at the Duke Business School, and Anthony is at Tennessee University Data Science Department. And this also includes two clinical collaborators or health policy collaborators, Anne Spalding and Jack Chatwal. Anne is with the Emory Rollins School of Public Health, and Jack is with the ITA at Mass General Hospital. So let me tell you about hepatitis C. Hepatitis C is the leading cause of liver cancer cases, and liver transplants in the US. There are more than 3 million people in the US infected with hepatitis C. And I'll show you a figure which was a sort of like the aha moment for me to work on hepatitis C space. This figure basically shows that as of 2006, the number of people infected with hepatitis C has surpassed those infected with HIV, right? If I tell you that HIV is a big disease, it's affecting, a sizable number of people, I don't think I need to make a case for it, right? But when we talk about hepatitis C, at least by that time, it wasn't my impression that hepatitis C had such a big disease burden on the society. Uh, and I had this conversation with Anne Spalding, who is at the Rollins School of Public Health. She's also an MD, hepatitis C treating doctor in correctional health facilities in prisons and jails. And she's super enthusiastic about making a contribution to eliminate hepatitis C. And I again this was a motivating factor for me to tap into this research area and then do something on it. Hepatitis C treatment landscape started to change from starting from late 2010s, early 2011s. What happened in the space is that up until that time, hepatitis C was deemed as an incurable disease. But starting from late 2010s, some novel treatment agents came into the space. Uh, and these therapies, basically, as compared with previous therapies, right, the previous treatment options required a long duration of treatment from anywhere from 24 to 48 weeks, and their efficacy was less than 50%. So the chance of cure was really less than smaller than flipping a coin. And the new treatment options, direct acting agents, they are highly effective. Their efficacy as of today is higher than 99%. They require short duration of treatment from 8 to 12 weeks, and they're all oral drugs. So you can basically take, oral daily pills, and they have minimal side effects. And because of these developments, many uh, health organ policy organizations, including WHO, issued statements arguing that the time has come perhaps for global elimination of hepatitis C. And when we talk about hepatitis C elimination, there is consensus that correctional health systems, prisons and jails cannot be ignored. This is a picture from a prison system in Georgia. And the reason why we cannot eliminate or ignore correctional health systems when it comes to hepatitis C elimination is because, let me let me quote from a famous rubber, right? In our discipline, it is more common to cite previous publishers, researchers, but here I'm going to cite a bank robber, Willie Sutton, who basically allegedly said that when he was asked why he robbed banks, he said this is where the money is. And if you flip the coin and ask a similar question to an epidemiologist today, right? If you ask an epidemiologist why we should focus on correctional health facilities for treating hepatitis C, the response would be similar. The response would be because this is where the majority of hepatitis C cases are. 17%, about 17% of incarcerated population in the US is infected with hepatitis C, and this corresponds to about 10 times higher disease burden as compared with the community settings. And prisons also, in addition to high prevalence, prison systems are ideal for identifying, testing, and treating hard to reach patients, right? They are like laboratories. Finding who is infected with hepatitis C in the population outside is very difficult, right? You need to do, patients may not link to care. It may be hard to identify these patients, but in a closed system like a correctional health system, it's easier to get screening done. It's easier to, once you detect, diagnose patients, it's easier to link them to care. So upon detection, managing these patients are easier as compared with the community settings. And a final reason is that about 95% of the inmates are released in less than 5 years. And upon their release, they are mingling and interacting with others in the society and spreading the disease. So while they are in the correctional systems, if it is at all possible to screen and link them to care and treat them, there is this thought that it might be a cost-effective strategy. So then you may be naturally asking, then why don't we treat every infected inmate, right? Why do we need to prioritize treatment decisions behind the bars? The main reason is the cost of hepatitis C treatments. When they first came into the market, the cost per pill was about $1,000, and patients were expected to be on treatment for 12 weeks, taking one pill per day. So, on average, per patient cost would be somewhere around 84 to $100,000. And of course, the drug costs, there are discounting schemes, etc. But it was still, after all discounting, these costs were still unbearable for the correctional health systems. As a matter of fact, a study has shown in 2014 that treating all incarcerated people would cost more than twice of the entire healthcare spending allocated for correctional health systems. So this is not feasible. And as a result, because of this cost burden, correctional health facilities couldn't provide treatment to all hepatitis C infected inmates, right? They were strained by these costs, and it was very common for inmates to sue states for withholding hepatitis C drugs and we have observed this in multiple states. In current practice, what happens is the Federal Bureau of Prisons, they recommend prioritizing treatment among inmates with hepatitis C infection. And current treatment prioritization guidelines and published literature suggest considering disease staging, remaining length of sentence, and injection drug use status. But in practice, prioritization is mostly based on health status only, even though significant variation exists in practice. And also, even though guidelines mention these three components, it's not clear how these three components would be factored in when it comes to prioritization decisions, which motivated our research problem where our key research question was uh, what should an ideal hepatitis C treatment prioritization policy for correctional health systems look like, considering these three factors mentioned in the Federal Bureau of Prisons report, including disease staging, such as cirrhotic versus non-cirrhotic patients, including length of sentence, short versus long length of sentence, and including injection drug use status. And just to motivate the problem, let me give you a quick example or quick exercise. So if you think about two patients, suppose you have an injection drug user whose length of sentence is 1 year, and a non-injection drug user whose length of sentence is 5 years. And suppose the non-injection drug user is sicker and injection drug user is healthier. And out of these two patients, you have the resources to treat only one of them. And you are making these treatment decisions on a yearly basis because you have annual budget. Now the question is, if you can treat only one of these patients, which of these patients would you treat? Would you treat the healthier injection drug user who would be released sooner? Or would you treat sicker non-injection drug user who will stay in the system for a longer time? And quickly you'll realize that there's a trade-off, right? By treating the injection drug user who would be released soon, you may eliminate infections in the community, right? Because that individual could be released fully cured and treated. And treatment works as a cure. Once you are treated, you can no longer infect others with hepatitis C. Whereas by treating the sicker non-injection drug user, you can save his or her life because that patient will stay in the correctional health system for a longer time. And if that person is not offered, if they are not offered treatment today, they may not have the chance to be treated before dying from hepatitis C in the next 5 years. Okay. So our overall modeling approach, we basically took a four-stage approach. In the first stage, we built an analytical model to identify near optimal policies. In the second stage, we use real data to develop and validate a high-fidelity agent-based simulation model. In the third stage, we assess the performance of the near optimal policies generated from the analytical model through the agent-based simulation model by using agent-based simulation model as a testbed. And finally, we designed an implementable decision support tool and delivered it to the end users. So let me talk about hepatitis C disease progression a little bit and that will help you to better understand the underlying disease progression model. Hepatitis C infection causes inflammation and ultimately scarring in the liver, which is referred to as fibrosis. Liver has soft tissue, and upon infection and over time, some scarring occurs on the outside tissue of liver. And again, this degradation is measured by a standardized scoring system, which is called as Metavir scoring system, ranging from where the stages are ranging from F0 to F4. F0 is the mildest stage, and F4 is an advanced stage of hepatitis C infection. And patients who have been at advanced stages of hepatitis C infection may further develop decompensated cirrhosis or hepatocellular carcinoma, which is a common type of liver cancer. And once they are in the decompensated cirrhotic stage or hepatocellular carcinoma stage, they may die from hepatitis C. The target population for treatment include F0 to F4 patients. So what we did is we built an underlying natural disease progression model, starting with uninfected states and capturing the progression characterized by this standardized scoring system, ranging from F0 to F4, and then at F4, from F4, they can go to DC, which stands for decompensated cirrhosis, HCC, which is referring to hepatocellular carcinoma, and from these two states, they may die from liver-related deaths. Of course, they may also die from other causes like background mortality, right, heart diseases, car accident, etc. And all of these patients from F0 to F4 stages are candidates for treatment. Once they are treated, if the treatment is successful, which is very likely, then they will achieve SVR, which stands for sustained viral response. So basically, their viral load is contained, suppressed, and hepatitis C infection is no longer a life-threatening disease for them. But there is a possibility of being reinfected. So just because they are treated now doesn't mean that they cannot get reinfected. So even though they are treated now and cured now, if they are exposed to virus again in the future, they may be reinfected. And as for the states of the patients, we consider patients' health states, patients' length of sentence, and age. Okay, so obviously, liver health state is changing probabilistically over time, and remaining length of sentence and age are changing deterministically over time. And we modeled this system as a restless multi-bandit model, where the idea is we have n patients, and out of these n patients, each of them are following an underlying natural disease progression stochastically, and out of these n patients, we can only treat a subset of them, and the decision is which of these patients, subset of patients, we should prioritize and treat given our resource constraints. And if you think about the state space, you would quickly realize that there's a large state space, so it is not possible to solve this problem to the optimality. And when dealing with these problems, it is pretty standard to see if these problems, these models are indexable. And we have shown that under some reasonable conditions, our problem is indexable. As a result, we can utilize some approximation algorithms. And we have also shown that we can come up with Wittels index for this problem, and Wittels index for in our specific setting for F4 patients is always non-increasing over time, which is a useful theoretical finding that I'll talk about in a minute. We were also analytically characterize the structure of the Wittels index exactly, and that exact characterization helped us to understand how Wittels index would behave under different settings. So through this closed form characterization, we were able to, before conducting any numerical experiments, we were able to anticipate that Wittels index performance would be degrading as the resource constraints are relaxed a little bit. Then what we did is we validated our model. We compared the outcomes of our underlying disease progression model with some published studies with real-world evidence, and we have shown that our outcomes, model-generated outcomes, are within reasonable ranges. We have also validated our underlying simulation model. So this validation basically gave us the confidence that we can rely on the estimations from these prediction models, underlying models, when making benchmarking decisions. And this is what the simulation model, agent-based simulation model looked like. We basically had incarcerated population and community, and within the community and inside the behind the bars, there are interactions among patients, and those interactions may lead to infections. And upon infection, disease progression starts, right? So this is an infectious disease model, captured model through agent-based simulation modeling. So with that, I will shift gears and discuss some of the results. Let's go back to this question of whether we should prioritize patients with short versus long length of sentences. And we have shown that we basically looked at this decision as a function of treatment capacity. The first figure that you are seeing is looking at when we can treat only 5% of the patients, and we are varying the infection rate outside prison systems and treatment rate outside prison systems. The blue dot that you are showing is corresponding to the current infection rates or by that time infection rates and treatment rates outside prison system. The conclusion from this figure is that with the current data, that the current estimates that we have from real world, prioritizing patients with longer length of sentences over shorter length of sentences makes sense if the treatment capacity is really tight, if we can only treat about 5% of patients on a yearly basis. But as we increase the treatment capacity to 10%, 15%, we quickly realize that in those cases, when the treatment capacity is a little larger, it might make sense to prioritize patients with shorter length of sentences. And the reason is that if you think about the trade-off, if you can treat only 5% of the patients, if you don't prioritize those patients with longer length of sentences, they may never have the chance to be treated before they die from this disease. But when the length of sentence is shorter, when the treatment capacity is larger, like 15%, by prioritizing these patients with shorter length of sentences, we can prevent some infections that may happen in the community because they will be released soon. But at the same time, because the treatment capacity is a little larger, we may still save these patients with longer length of sentences because those patients with longer length of sentences are likely to have future access to treatment before they die from this disease. Again, because here the treatment capacity is is triple of what we have seen in figure 1A. And you may be wondering if these are realistic capacities. So these are the treatment capacities from different states. If you look at Texas prison system, they're about 412 so there are about 17,000 infected individuals inside that Texas prison systems, and out of them, only about 400 of them receive treatment on an annual basis. Whereas if you look at which corresponds to a number less than 5%, but if you look at the Indiana prison system, out of 3,400 infected inmates, about 450 of them receive treatment, which corresponds to a capacity slightly larger than 15%. Right? So depending on the prison system, depending on the capacity, the decision could be different. There is no one-size-fits-all recommendation here. The next question that we ask is whether we should prioritize IDU versus non-IDU patients. And here I'm going to keep this discussion quick so that I will have a chance to discuss the second project as well. The key finding that we have here is that IDU injection drug users shouldn't be prioritized unless they are at an earlier stages of infection. And also, they shouldn't be prioritized unless reinfection rate outside in community settings are really well controlled. And why are we prioritizing? Why it might make sense to prioritize injection drug users in earlier stages of infection, because if they will ever receive treatment, it makes sense to provide them treatment in earlier stages, such that mainly because when they're in earlier stages of infection, they have a longer life expectancy, and the longer the life expectancy they have a larger window of infecting others. So by basically providing treatment at earlier stages of infection, we might eliminate, avert a higher number of infections. So building upon these findings, we developed an Excel-based decision support tool. Why Excel? Because this is what the prison systems were capable of using, and this was the type of tools that were available to them. Right? They didn't have access to advanced software solutions, and so, the end users were able to change many of the input parameter values, run their analysis, and make prioritization decisions accordingly. And Spalding, our clinical collaborator, basically get these solutions implemented in 2 prison systems. And she also became a champion in disseminating and promoting the solution in several among several of her colleagues. In terms of dissemination, in addition to the decision support tool, we published this in multiple outlets. So I'll highlight 2 of them. The first one is a clinical journal, Annals of Internal Medicine. The impact factor is, I think, over 20, highly regarded journal in the clinical community. And here we focus on, we mainly published the findings from the agent-based simulation model. And we also published an OR paper on this work where we mainly focused on the theoretical model. So with that, I'll shift gears and talk about blood supply chain management problem, blood collection operations. Maybe I'll keep this shorter so that we'll have some meaningful time for discussion. This was collaborative work with American Red Cross. American Red Cross is the largest supply of blood and blood products in the nation. They collect about 40% of nation's blood supply. They collect about 5 million blood units each year, which are processed into more than 7 million blood products, including red blood cells, platelets, plasma, and cryoprecipitate, which is what we focus in this project. For short, I'll refer to this item as cryo, this product as cryo, in the remainder of this presentation. Maintaining sufficient quantities of blood products to meet the needs of patients is a delicate balance, primarily due to the fact that primarily due to the perishable nature of these products. Even though a large portion of population is eligible for blood donation, very small percentage in reality donate. And because of that, there is a constant need for blood and blood products. So with that, I will show a quick video highlighting some of the important angles in this project. Let me do that quickly.
Every 2 seconds, someone in the U.S. needs a blood transfusion. That someone could be an accident or burn victim, heart surgery patient, organ transplant patient, or someone receiving treatment for leukemia, cancer, or sickle cell disease. At the American Red Cross, we understand that this someone is not just a patient. It's a loved one, a grandparent, a mom, a child, who needs that blood donation to stay healthy, to treat an illness, to survive. Volunteer donors are the only source of blood and platelets for those in need of transfusions. And every day, the Red Cross must collect nearly 14,000 blood donations to meet the needs of patients at hospitals across the country. As the largest single supplier of blood products in the U.S., the Red Cross plays a critical role in our nation's healthcare system. The need for blood is constant, and the Red Cross must continuously look to implement operational efficiencies and innovative solutions to meet hospital patient needs. Let's look at one aspect of the blood production process more closely. After a generous volunteer blood donor rolls up a sleeve to donate whole blood, that pint is sent to a Red Cross production facility to be processed into different blood components, including red blood cells, platelets, plasma, and cryoprecipitate, or cryo for short. That's why just a single blood donation can help save more than one life. One blood product that can be particularly challenging to provide is cryo. Cryo plays a critical role in clotting and controlling hemorrhaging and is often used in the treatment of massive trauma and major diseases. Last year, the Red Cross provided more than 600,000 cryo products to hospitals across the country. The challenge with cryo? Well, almost all other blood products can be processed within 24 hours of donation. Cryo has only 8 hours after donation to be processed. The clock is ticking, and the demand is increasing. To develop a streamlined solution, the Red Cross worked with researchers from the Georgia Institute of Technology to increase the amount of whole blood that can be processed into cryo in our southern region. The researchers delivered. They developed a mathematical model and analysis that led to the implementation of a new decision support tool. With this new tool in place, the Red Cross expanded the capacity to collect and process cryo. We know that the journey of blood from the donor arm to the recipient arm is critical. That's why the Red Cross is dedicated to providing an adequate blood supply for patients who depend on us. Nothing is more important than delivering the mission at the Red Cross. Our mission is to help save lives.
So as we've seen in the video, cryo is an interesting product. It's different from all other blood products in the sense that upon collection within 8 hours, it has to be brought back to the manufacturing facility, processed, and be frozen. Otherwise, you cannot make use of cryos. And the way that it historically it worked at the American Red Cross was that it was a manual labor intensive process. Basically, in those manufacturing centers, there are only about 8, 9 of them in the entire nation. Cryo, if they had cryo experts, some of those centers did not. Those cryo experts were sitting down at the beginning of every week, identifying their targets for cryo production for that specific need and designating certain sites as cryo sites. When I say certain sites, think about mobile blood drives. You may have a mobile blood drive to your university or to your community center, right? So those mobile drives are scheduled months in advance, but these cryo experts are going over each of these mobile blood drives and we're deciding which of these mobile blood drives should be designated cryo drives or cryo collection sites. So that the demand could be met. And throughout the week, they need to dynamically adjust those schedules because their projections could have deviated from the reality, right? So it's a dynamic decision-making process, but very labor intensive. And as I mentioned, some of the sites didn't even have those cryo experts. So our objectives are threefold: optimize collection process to ensure a balanced and consistent supply of cryo, maintain low transportation costs, and automate the process. And we consider two models, non-split model and split models. Non-split model refer to the historical collection model, where, as I mentioned, the collection sites, blood drives, were either pure cryo drives or pure cryo collection sites or non-cryo collection sites for the entire day, meaning that if there's a scheduled blood drive from 8 a.m. to 5 p.m., and if your site is a designated cryo site, they were basically collecting whole blood units for the entire day, knowing that those collected blood units will be converted into cryo. And in order to do that, they need to be brought back to the manufacturing facility. But because collection windows are typically longer than 8 hours, adding traffic constraints, etc., what they did is they scheduled midday pickups where additional vans went to the collection sites, collected these blood units or picked up those blood units collected earlier in the day, took them to the manufacturing facility, and the remaining blood units collected in the second half of the day was brought back to the manufacturing facility by these mobile blood drives. Okay? So of course, it made sense to do it that way from the perspective of meeting the cryo demand, but it was very costly primarily because of these additional midday pickups. These midday pickups were the major cost item for these cryo collection sites. for these cryo collection operations. And we considered a very intuitive split model, which wasn't part of, which is what we proposed, right? And if you think about it, it's very intuitive. And what we suggested is that every single site collects blood units for cryo in the second half of the day. So if you look at basically collection size 3 through 6, right, they are collecting blood units, and collection is identical. It doesn't matter if you collect for cryo or something else. But those blood units, every single site would collect for cryo in the second half of the day. And just doing that may not be sufficient to meet the cryo targets. And if that's the case, we would designate selected sites as pure cryo collection sites, such as site number 1 and site number 2. And if certain sites are pure cryo collection sites, again, depending on the scheduled collection window, which happens months in advance, you may still need a midday pickup. But, we just basically looking at visually, you would quickly realize that, that by doing that, we could eliminate a sizable number of midday pickups, right? Super intuitive, quick solution. We had these insights maybe within the first 2 weeks of working with them. But of course, we need to make a case. We need to do rigorous analysis to convince the end user stakeholders that there is some merit in doing so. And in order to do that, what we did is we very quickly thought about a greedy heuristic, which was intuitively appealing, computational simple, but the downside was that it didn't have any provable performance guarantee. We also formulated this problem as a Markov decision process. And the advantage is it's a more formal, structured model for sequential decision making under uncertainty. Quality of resulting policy could be estimated or could be approximated, but computationally it's more demanding, and parameterization wise it was more challenging. So, and in the end, I'll talk more about it in a few minutes. In the end, we implemented greedy heuristic, but used the MDP solution approach to benchmark the quality of the greedy heuristic and quantify the performance of the implemented greedy heuristic. Again, in the interest of time, I'll even spend more time with technical details here, but this is what the state space looked like. We basically, for each site, we had possible, 3 possible states: the collection for the current day, targeted collection for the next day, and the targeted value. And then there were some constraints, such as, if you're going to do any cancellation, this had to be done at least 2 days in advance. Last minute cancellations were not allowed. So what we did is we basically relaxed some of these constraints and to generate a lower bound. And we also, by doing some analytical tricks, we also came up with an upper bound. And we basically came up with a bound for the optimality gap by basically, looking at the differential between the upper bound and the lower bound. And this optimality gap was useful as a benchmark for assessing the quality of the solution by the MDP policy, and also for assessing the quality of the greedy heuristic. If you look at the numerical results for the non-split and split model, separately for the MDP approach and greedy heuristic, over 4 weeks, we have quickly realized that the MDP solution had about, because we sold it to, approximately, not to the optimality, because of the curse of dimensionality. We have noticed that the optimality gap for MDP was about 5%, and the optimality gap for the heuristic solution was always less than 15%. So the gap between the two was almost always less than 10%, which basically gave us a basis to believe that the heuristic solution was reasonable enough, was promising, right? Absolutely better than what they are doing in current practice, and competitive as compared with the more formal MDP-based solution. And again, similar to the Prism healthcare setting systems, American Red Cross didn't have access to, advanced software solutions. They were using a very earlier version of Excel. They were using Excel 1998. We developed some solutions in Excel, later version in Excel, but they couldn't run it because again, they had an earlier version. Uh, that heuristic solution was very easy and practical to implement in Excel. We came up with similar to the Prism project with the decision support tool solution in close discussions with the stakeholders. And here are some snapshots. And they implemented what they did is from the delivery of the Excel-based solution until the implementation, they took about 2 years. And in those 2 year periods, they run some pilot studies, some experimentations in practice. Initially they started with changing the practice only on Fridays, because they wanted to be risk averse. If they ever missed the target significantly, right, that would lead to a big national crisis. So conservatively, they were piloting, collecting some real world data, comparing them with our computational results, and once they felt more confident that their experimentation results were aligned with our computational results, uh, they had full confidence for full implementation. Initially, they implemented in the southern region, which accounted for over 120 hospitals. And upon implementation, so before implementation, they were able to achieve weekly cryo collection targets only about 50% of the time. And after implementation, they were able to meet the target over 87% of the time. And the only exception, or one of the few exceptions was just end of the year 2017, because of this end of year effect, few people donated, but overall, the success rate has been pretty high. And in addition, they were able to collect more cryo units at a lower cost. To be more specific, they were able to increase their cryo collection volume by 20% at a 40% decreased cost, which basically meant that the solution approach was not a cost-effective approach only, but it was a cost-saving approach. The solution was very well received by the leadership team at the American Red Cross, and at that point, basically, they had full confidence in the solution, and they became the champion of promoting this solution within American Red Cross. Again, our collaboration started with the southern region, but at that point, leadership team at the American Red Cross spoke with leadership team from other regional, other manufacturing facilities, regional centers. And in a short period of time, again, keep in mind that it took 2 years to get this implemented initially, but from the initial implementation at a one manufacturing facility to the national level implementation, it took less than a year. So basically, after the initial, within a short period of time, our proposed solution approach was implemented by the entire Red Cross facilities throughout the nation. So dissemination, again, beyond practical impact, we published this work in 2 journals. The first one came out in Interfaces or Informs Journal on Analytics is the recent name. And we did that because our work was selected as one of the finalists for the France in the France Edelman competition, and this was one of the requirements where we focused on the practical impact and challenges working with practitioners and some more nuances along these lines. And another work, more technical work, technical development, came out in EMSOM journal. So with that, I will wrap up. I know that I took longer than I initially planned for, but I think we have at least 6 good minutes for any questions and discussion. So with that, I'll stop sharing. I don't know if there are already any questions, and the questions doesn't have to be about the specific projects. If you have broader level questions, I'm also happy to take them. Again, my biggest motivation for doing this was to hopefully help at least some of the junior researchers. Thanks.
Yeah, Turgay, thanks for the talk. So I'm looking through the questions that are posted, and there are actually quite a lot about kind of this. How do you scope good projects? How do you know if there's good incentive alignment? And so I think I'll start by kind of trying to group a few of these together. But in terms of choosing a project to work on, I guess there's two questions. One is how much does your interest in the project factor in? And then second, how do you know if a project is going to, in the early stages, result in a good ORMS or healthcare paper?
Good. So interest is easier to assess, right? So very early on, you can assess if you're interested in doing that or not. Publishing, getting the work published in informed journals. Uh, I think you would get a sense, you would get a sense again, going going back to this, blood supply chain management problem. We knew very early on that a heuristic solution would probably work, but we didn't have evidence. We didn't have any benchmarking, and for proving it, we needed to do some formal analysis. And the moment that I knew that we would need to do some formal analysis uh, to to support the implementable solution, I know that there will be interesting, theoretical mathematical work, to support the implementation that would be of interest to informs community because A, it's a practically challenging problem. It is a real problem. It is supported with real data. Uh, it is not a, outdated problem that has been studied by 100 other people. And there is good use of some of the tool solution approaches we have in the community. So these are reasons, these are some of the reasons for deciding whether there's a good path towards such informed publications or not.
Yeah, thanks. And then I'm gonna ask kind of a couple questions that are related. So the first is who initiates like a good practical project? Is it the academic or the practitioner? Like who tends to reach out first? And I'll let you answer it first, and then I'll ask kind of a final question.
I think it's a two-way street, right? Very early on in my career, it was almost always me reaching out to, practitioners. Later on, once you establish yourself in the area in the local region, right? People hear about your names, your collaborators talk about, just talk about, your successful collaboration, and people tend to reach out to you. So, for the past couple of years, I don't recall reaching out to anyone. Of course, I mean it depends, but most of the time, they have started reaching out to our group because they've heard about some of the collaborations, successful collaborations we have had. So it's a two-way street.
Thank you. And then there's some questions here about like where do you see the field going? Like how do you find areas that are going to be interesting or popular in the future? Some of these areas that have been popular before, like breast cancer care and some of the work you're doing with like Hep C, are these areas that you think will continue to be popular, or do you think people need to start looking in
I mean,
new areas?
I think, instead of, I mean, it's hard to predict what's going to be popular, right? It's similar to predicting, what the stock market would look like. But I think, I would focus more on the likelihood of success. And I think likelihood of success would be largely driven by data availability. And also to what extent these problems have been studied in the published literature, right? So for me, rare diseases or ultra rare diseases are super interesting, but I'm currently not working on any of them because data limitation is a big problem, right? I'm interested. Rare diseases, if you do something meaningful, it would be very useful, both practically and academically. But I know that data limitation is a challenge there. And with a similar level of effort, if you work on some areas where data availability is not that big of a challenge, but at the same time, problems are you know, comparably interesting, if not equally interesting, I think that would increase the likelihood of success.
Thanks. And then I think we have time for one more question here. So, how do you move from the type of math you're doing to these more complex mathematical models to implementation? Like, what barriers are there to think about in terms of getting these math models implemented in the real world? How do you convince practitioners? How do you get them to care about these publications and so on?
Good, that's a good question. And I would say that there is not always 100% mapping between the underlying math models and practical solutions, right? There are trade-offs. Uh, and some of these advanced mathematical solutions are not even possible to implement depending on the setting, right? Sometimes they don't have the capabilities, sometimes they don't have the software solutions, right? You need to basically make some practical choices. As I mentioned in the very first project, we we had a multi-armed bandit model, based solution, but it wouldn't be uh, possible to get these implemented because there was no way that we could have programmed them in an Excel-based setting. And I know that anything more complex than Excel wouldn't be acceptable to them. So the ultimately implemented version in Excel deviated a little bit from the mathematical solution that we provided, but it was motivated, it was building upon these mathematical foundation, right? In different ways. Either the mathematical foundation provided a benchmark for assessing the quality of the responses, or benchmarking or bounding the optimality gap, or it motivated the practical implementation. So where I'm going with this is that depending on the setting, if you're working with big tech companies, right, it may be possible to get those solutions, complex solutions, implemented as is. If you're working with NGOs, smaller size companies, hospital settings, you may need to deviate a little bit from these, foundational solutions. But at any rate, as long as there's a linkage, reasonable linkage between the two, I think it's plausible, possible. And I think, our group has done that. Many other research groups have done that. It's also possible to, get it disseminated to both practitioners and research communities.
Awesome. Well, thanks again, Turgay, for sharing your work and sharing your insights. Especially, it seems like there are really a lot of junior scholars in the chat based on the questions here. So I guess if anyone is interested in reaching out, I'm sure they can find your email on your website. But other than that, I think that's it. So we're gonna wrap things up here on this really good. I don't know if you have any final words.
Thank you for
Thank
the
you so
opportunity.
much. Yeah, thank you so much. It was an excellent talk, very insightful.
Thank
Right.
you for the opportunity, and I wish you all a great weekend.
Thank you.
Thank
Thanks,
you all
Beth,
for
for your help with
participating.
organizing.
Yeah,
Right.
No
See ya.
problem. Have a great weekend.
you
You too.
too. Bye.